ठीक है, ओके ओके। हाँ, कह रहे हैं जा रही है। हेलो, हाँ, नेक्स्ट साकिब, नेक्स्ट स्लाइड। Bismillahirrahmanirrahim. I'm Dr. Tabe Rasool, Assistant Professor, Rheumatology, DIMC. Apology for getting too much late because some technical issues related to the voice. So without any further delay, we are going to start. Although even at this point, I'm unable to listen my moderator as well, but he says that your voice is being delivered. So let's start. The topic of today's lecture is anemia, approach to a patient with anemia. Deficiency, by definition, decreased oxygen carrying capacity due to the diminished or decreased erythrocyte mass. Maybe due to erythrocyte loss, bleeding, or blood loss that we commonly see in road traffic accidents or some other bleeding disorders or any other reason. Low erythropoietin because, leads to decreased production, decreased marrow response to erythropoietin, and decreased contents also can result in decreased production like iron deficiency, B12, folate deficiencies. The other possible causes are increased erythrocyte destruction, means the marrow is forming the good amount of red blood cells, but it's being destroyed in the periphery, in the reticuloendothelial system. Next, please. Sakib, next. So, measurements of anemia: hemoglobin, hemoglobin of 100 ml of whole blood gram. Hematocrit is percentage of the sample of the whole blood occupied by the cellular portion, and RBCs, millions of the red blood cells per microliter of the whole blood. MCV, these are the little definitions. Normal or is between 80 to 100. If it's more than 100, then it's macrocytic, so it's a larger in size. The normal, if between 800 is normal, I already discussed. Less than 80 is microcytic anemia. RBC distribution width is the standard deviation of the red blood volume divided by mean cell volume into 100. The normal value is 11 to 15. If limited, suggests large variability in the size of RBCs. That's some cells may be of the normal size, some may be microcytes, others may be macrocytes. So this is a relative variation in the size. Next, please. Lab definition anemia: if hemoglobin concentration is less than 12 gram% in female and less than 13.5 in the males. Hematocrit less than 36 in female and less than 41 in males. The relative decrease in hemoglobin is values. The difference between male and female is self-explanatory, is related to the blood loss in the menstrual cycle. Next, please. So symptoms of anemia, what the patient present with usually fatigue, exertional shortness of breath or dyspnea, bounding pulse, lethargy, confusion, a lack of concentration. All these can be the features. Muscle cramps, postural dizziness. If there is volume loss, say for example, is there increased loss of the blood or any hemorrhage or bleeding from any side, can lead to relative decrease in the volume, which results in syncope because of decreased perfusion to the central nervous system. Next, please. Special consideration in determining the anemia or the acute bleed. A drop in the hemoglobin hematocrit may not be apparent for first 36 to 48 hours due to blood loss. Pregnancy in third trimester, RBC and plasma volumes are expanded by 25 to 50% respectively. Labs will show reduction in hemoglobin, hematocrit, RBC count, often to anemia, corresponding to the level of anemia. But according to RBC mass, they are actually polycythemic. So volume depletion, patients who are severely volume depleted may not show anemia until after rehydration. Say for example, if a patient comes to us with profuse diarrhea and vomiting, he is volume depleted. So if we get sample of that patient, that might show normal hemoglobin. But when we rehydrate, because this is relative to the circulating volume. If the volume is low, then our red cell count will relatively be high. So when after rehydration, we check the hemoglobin concentration, that will be low. There's huge difference. We often see this in our practical life. Next, please. So the RBC cycle, we all know, this is the first thing we read in the physiology. So without wasting time in this, next please, we will move towards the approach rather than the physiology. Next please. So this is the normal peripheral film. You see the biconjugate disc RBCs with mild centropellar, but if there is iron deficiency, then you may have a lot of centropellar. Next, please. So the causes of anemia, because it's of paramount importance, that unless we know the cause of decreased hemoglobin concentration or anemia, we won't be able to treat that patient properly. So blood loss, erythrocytes, bleeding, this chronic GI bleed, menstrual losses. I haven't. To be very honest, chronic GI, menstrual loss, acute hemolytic significant GI, and retroperitoneal bleeds may also all lead to the blood loss anemia. Next, please. So we know that erythropoietin is of paramount importance for the generation of the RBCs. So patient with chronic kidney disease will have anemia that's usually normocytic and anemia of chronic disease because of decreased erythropoietin. Low retic count because of decreased production, because erythropoietin is responsible for the production of red cells. Frequently, peripheral smear in the uremic patients show Barr cells. I will later show you in the slide. Are echinocytes also called. Target hemoglobin for patients on dialysis 11 to 12 gram per deciliter. Administer erythropoietin or darbepoietin weekly, but make sure that iron stores are very good, because if the patient is iron depleted, you administer erythropoietin, you won't see any increase in the hemoglobin concentration. Next, please. These are the echinocytes, Barr cells, a common finding seen in patients with uremia or chronic kidney disease. Next, please. So anemia due to decreased response to erythropoietin, or as already mentioned, if the iron is deficient, erythropoietin won't work, B12 deficient won't work, folate deficiency won't work, anemia of chronic disease may not respond to erythropoietin. So make sure that the contents are in quite good number, good stores are there of iron, B12, which are required for the synthesis of the RBCs. Only then erythropoietin would work, otherwise it won't. Next, please. So anybody to decrease response to erythropoietin, again, these are the pregnancy, lactation, normal growth, blood loss, intravascular hemolysis, gastric bypass, malabsorption. Iron is absorbed in proximal bowel, decreased absorption in the celiac disease, inflammatory bowel disease, where the site of absorption is there actually for the iron. If iron is not absorbed, then the hemoglobin would not increase in relation to the erythropoietin administration. In these cases, if there is any bowel-related disease, then it's better to replace the iron via parenterally. So many of the patients may present as PECA, tendency to eat ice, clay, starch, crunchy materials, may have palar, chylonachia of the nails, bituria. Peripheral smears show microcytes, hypochromic red cells, and marked anisopoikilocytosis. Anisocytosis means decrease in the size of the RBC, and poikilocytosis is the decrease in the shape of RBCs. Next, please. This is typical iron, because the central pillar is there, showing in multiple states. Next, please. This is typical chylonachia. There is some other associated problem, maybe a fungal infection because nail restriction. It's not really a feature. You may have brittle or spoon-shaped nails. Initially, there is flattening of the nail, which is called flattynichia. But in advanced cases, if not treated here with the iron replacement, then you may have chylonachia. That's typical spoon-shaped of the nails. Next, please. What findings would you see in laboratory decreased serum iron levels? That's less than 60 micrograms per deciliter. High iron binding capacity, that's TIBC, total iron binding capacity, would be high, more than 60 microgram. Low ferritin levels, less than 10 micrograms. But make sure that there is no concomitant inflammatory disease, like patient with arthritis, patient with any infections, because apart from ferritin showing the iron stores, it's also an acute phase reactant as well. So if there is any acute inflammatory condition, then the iron ferritin levels may falsely be high, not because of adequate iron stores, rather because of the acute inflammation. So make sure in inflammatory conditions, then serum iron and TIBC are the good parameters to check whether the iron is in a good amount or not. Next, please. Treatment of iron deficiency anemia is the replacement orally. If there is no GI-related disease or upset stomach or any short bowel or any prior surgery to the small intestine, especially proximal, because the site of absorption, then in that cases, oral iron administration would be effective, along with vitamin C, which also increases and facilitates the iron absorption. So if the patient is having any GI-related issues, then the parenteral iron need to be replaced. Next, please. In order to decrease response to erythropoietin, we had already mentioned these are all the causes: B12 deficiency, deficiency of B12 may also lead to other neuropsychiatric symptoms like gait ataxia, spastic paraparesis, psychosis, loss of vibration sense, dementia. These are other features related to the B12. Apart from B12 working as a cofactor for the synthesis of DNA in the red blood cells, but if that's not in the required amount, then patient may have symptoms apart from the hematological, so they may have neuropsychiatric symptoms as well. In cases of B12 deficiency, you may have hypersegmented neutrophils in peripheral film of patients with B12 deficiency, and possible basophil stippling may be seen, although basophil stippling also seen other conditions. Next, please. This is vitamin B macrocytes in hypersegmented neutrophils. Many segments of the neutrophils are shown in the central place of the blood cells. Next, please. How to replace 1,000 micrograms intramuscularly monthly unless patient has severe thrombocytopenia or any bleeding disorders. In that case, you may replace the patient with IV. Otherwise, the recommended is intramuscular, 1,000 to 1,000 micrograms per day, or 1,000 to 2,000 micrograms per orally daily. If there is no GI-related issues, especially the ileal disease, because the site of absorption for the B12 is ileum. Next, please. Anyway, to decrease response to erythropoietin, again, maybe because of folate deficiency, we had already mentioned. So low folate, increased serum homocysteine, normal methyl malonic acid often occurs with decreased oral intake because stores are very limited in for the folic acid. Increased utilization in increased cell turnover in patients with oncological conditions or hematological malignancies. May be decreased because of impaired absorption. So folate is normally absorbed in duodenum and proximal jejunum. And patient with celiac disease, regional enteritis, amyloidosis, inflammatory bowel diseases may present with folate deficiency. Also, alcoholic patients may also present with the folate deficiency. Smear shows macrocytes with hypersegmented neutrophils, but B12 levels should be normal. Next, please. This is folate deficiency. Again, hypersegmented neutrophil will be seen, but this should not be mixed with, because in patients, if you assume that patient has folate deficiency, which give you the similar picture like macrocytes, hypersegmented neutrophils. But please do check serum B12 levels, because if you are treating a patient of folate B12 deficiency by replacing only folic acid, you may correct the hematological part, but the neuropsychiatric symptoms would worsen and lead to irreversible neurological deficits. So in patients with macrocytic anemia with raised MCV more than 100, you find hypersegment neutrophils. Never check alone only folate or replace. Also check B12 and folate both. And if B12 is deficient, that must be replaced. Not only the folate replacement should be done. Next, please. Treatment of folate deficiency, 1 to 5 milligram per orally every day. B12 deficiency must be excluded, as we have already mentioned. Next, please. Vitamin deficiency versus folate. We have seen, you can see the differences. MCV will be high, similar to macrocyte hyperpigmented neutrophils. Pernicious anemia may be related to because of intrinsic factor deficiency in B12, but not in cases of folate. Homocysteine may be elevated in both, and methylmalonic acid is elevated in B12 deficiency, but is normal in patients with folate deficiency. Next, please. Anemia due to decreased response to erythropoietin. Again, anemia of chronic disease is also a feature. Usually normocytic normochronic anemia, that's MCV is between 80 and 100. Occurs in people with inflammatory conditions such as collagen vascular disease, lupus, rheumatoid arthritis, inflammatory muscle diseases. Iron replacement is not necessary, may benefit from erythropoietin supplementation. But again, before replacing erythropoietin, contents need to be replaced or should be sufficient in order to give proper response. Next, please. Anemia due to decreased marrow response, thalassemia, microcytic anemia, defect in the either alpha or beta chain. That's actually the hemoglobinopathy, which leads to abnormal synthesis of the red cells, which are actually very susceptible to the hemolysis. Alpha thalassemia prevalent in African, Mediterranean, and Middle East and Asia. Beta thalassemia prevalent in Mediterranean, South Asia, India, Indo-Pak as well. We see a lot of cases of beta thalassemia, that's thalassemia major. Smear shows microcytes with target cells, but the RBC count will be high as compared to the iron deficiency. Next, please. Here you see microcytes, cells are smaller in size, but the RBC count, you see there's overcrowding. This count of the red cell is not that much decreased. Next, please. Hemolytic anemia or destruction due to hemoglobinopathies, again, sickle cell anemia is one of the causes. And aplastic anemia or hypoplastic anemia is decreased production of the blood cells from the marrow. There is decrease in all cell lines. May not be initially may present with only single cell line deficiency, but later on other cells may become involved. Some infectious causes of the aplastic or hypoplastic anemia are parvovirus B19. This parvovirus typically causes only red cell aplasia. Others may cause pancytopenia. Epstein-Barr virus, cytomegalovirus, and acquired aplastic anemia because of radiations and some chemicals, and hemolytic anemia. Next, please. Next, please. And this seems a very busy slide, as the hemolytic anemia is a broader term used for so many conditions. The problem may be related to the cell membrane, that's hereditary spherocytosis. The shape of the RBCs is not typical. Most common enzyme defect in the RBCs. It's an X-linked disorders, and there is rapid hemolysis. Patient is exposed to oxidative stress from drugs, infections, or toxins. TTP are thrombotic thrombocytopenia, microangiopathic hemolytic anemia. There is thrombocytopenia and microangiopathic hemolytic anemia, fever, renal insufficiency, and neurological symptoms. Typical triad, but in all cases, you may not find all the aspects of this triad. Schistocytes are typical in the peripheral blood smear. If you find a patient with decreased hemoglobin, decreased platelet count, do check for schistocytes and neurological symptoms. Hemolytic uremic syndrome, thrombocytopenia, microangiopathic hemolytic anemia, and renal insufficiency. TTP is more common in adult population, while hemolytic uremic syndrome is more common in children. Autoimmune hemolytic anemia is constitutes a very good number of the patients. There are so many autoimmune disorders in which hemolytic anemia may be associated, or sometimes it's only isolated conditions, autoimmune hemolytic anemia. The conditions which are associated with autoimmune anemia are SLE, mixed connective tissue disorders. These patients may have autoimmune hemolytic anemia. How to check? Warm antibodies are direct wounds test. IgG antibodies bind to erythrocyte surface. This is the most common type of hemolytic anemia. Can be caused by drugs. Treatment is usually with corticosteroid, splenectomy, or the immunosuppressive drugs, and even anti-CD20 rituximab has also been shown to be effective in preventing the further hemolysis. Cold agglutinin disease usually associated with common infections, mycoplasma related. IgM antibodies bind to erythrocyte surface, does not respond to corticosteroid, but usually is mild. And when you treat the underlying cause like the mycoplasma pneumonia or other infections, this will settle down by itself. These are the other infectious causes of hemolytic anemia. Malaria is very common. It's called the graveyard for the RBCs. There is huge destruction leading to splenomegaly, anemia, and babesiosis and sepsis also is one of the causes of hemolytic anemia. Trauma includes some snake or insect bites. I don't know what included in trauma, but yes, snake. These are the causes, release some toxins which cause the hemolysis. Next, please. Sickle cell anemia, you can see the sickling of the RBCs in the peripheral smear. Next, please. These are the spherocytes. These are the rounded RBCs rather than the biconcave disc-like appearances. Next, please. TTP or HUS, you can see schistocytes with the arrows. Next, please. Malaria. Apart from discrete red blood cell numbers, there is the presence of the malaria parasite within the red blood cell, which leads to destruction. Next, please. Babesiosis, again, intracellular parasite seen in the red blood cells. Next, please. Now, lab evaluation, we have just already mentioned with each, but in the hemolytic anemia, you can see indirect hyperbilirubinemia because of destruction of RBCs, heme and globin. Globin part is released and hemoglobin goes to the storage pool. So because the destruction, it releases the bilirubin, which is usually indirect. Increased LDH, again, an enzyme in the cell membrane. Because of increased destruction, you would find increased retic count. When there is peripheral destruction of the red blood cell, marrow tries to compensate this, and as a result, reticulocyte number would increase. More than 3% is sign of increased reticulocyte production, suggestive of hemolysis or peripheral destruction. Reduced or upset hepatoglobin levels suggest hemolysis. Hepatoglobin binds to free hemoglobin released after hemolysis. So hence the number is decreased. Next, please. Evaluating the patient with anemia, check hemoglobin, hematocrit. If female, less than 12, we have mentioned less than 13.5 in males, or hematocrit less than 41. If yes, the patient fits the criteria for anemia. If no, they are fine, then the lecture was not necessary. So next, please. Evaluating the patient with anemia, any history of medical problem that could cause anemia, like sickle cell disease, thalassemia, renal disease, hereditary spherocytosis. If already known, this is easy. If not, then you have to search for the possible causes that can lead to anemia. Next, please. Are there other cell lines also low, like WBCs and platelets are both considered aplastic anemia? There are some drugs that can cause also this. NSAIDs, phenylbutazone, previously used as an NSAID for the arthritis, now less commonly used because of availability of the safer NSAIDs. Sulfonamides, acyclovir, ganciclovir, antiviral drugs, chlorphenicol, anti-epileptic drugs like phenytoin, carbamazepine, valproic acid, all can cause aplastic anemia. Parvirus B19 leads to isolated RBCs or red cell aplasia. Consider hepatitis virus and HIV also. If patients' platelets are low along with this, then TTP or HUS may be considered. Must check smear for histiocytes for signs of microangiopathic hemolytic anemia. And if renal failure or E. coli exposure, HUS is more common because it usually follows a diarrheal illness in children, more common. If renal failure, neurological changes, fever, then this triad is typical of TTP, thrombotic thrombocytopenic purpura. Next, please. Is the patient bleeding? Any bright red blood per rectum, hematochezia or black tarry stool, melena? Check stool gag test or stool for occult blood. May consider sigmoidoscopy or colonoscopy because there are so many conditions like coronary cancer, inflammatory bowel disease like Crohn's disease, ulcerative colitis, or can cause blood loss, and acid peptic disease, hemorrhagic gastritis, all can lead to blood loss. Any abdominal pain or rectal femoral vena artery manipulation, consider retroperitoneal hematomas as well, which is detected usually by a CT scan of the abdomen. Next, please. We have already discussed this slide, MCVs, microcytic, macrocytic, check the contents like iron, B12, folate levels. These are all causes, and other causes may be alcoholism, myelodysplastic syndrome, some medication like hydroxyurea, azathioprine, methotrexate, all can lead to macrocytic anemia. Next, please. Any jaundice, elevated bilirubin, suspicious for hemolysis. If indirect hemoglobin is high, then this is suggestive with increased LDH and decreased hepatoglobin levels as well as reticulocytosis. Remember, in chronic hemolytic anemia, when the contents are deficient, like there is increased turnover initially, which leads to depletion of the B12, folate, and iron levels. In that case, this is exception because in hemolytic anemia you usually find reticulocytosis, but chronic hemolysis leads to depletion of these contents like B12, folate, RBCs. So as a result, reticulocyte count may be normal or even low in these conditions. So consider hemolytic anemia is there, but there is no inadequate marrow response, then the content deficiency may also be there concomitantly. Any sinus infection like malaria, babesiosis should be considered, usually present with febrile illness. Is Coombs test positive? This is suggestive of autoimmune hemolytic anemia. Consider some drugs or autoimmune diseases like lupus is very common. Next. Next, please. These are the few cases would have discussed, but because of the time constraint, we are finishing over here. Today's lecture. I'm sorry if I could have any questions, but because it's only one-way traffic, I only can deliver the lecture and cannot hear any voices over here for direct communication. But when you will be posted in medicine department, we are always there, or even you are not posted in medicine department, other department, you may come at any time regarding any confusion related to approach to the anemia or other medical related issues. Thank you very much.